The one thing we don't talk about that we don't have good data on is somebody comes in, let's say their sperm count, their total motile, the amount of moving sperm in their ejaculate is 500 million. So they're well within the normal range. They start testosterone therapy for several years. They come off, they're rebooted, so to speak. Now their total motile count's 150 million. Still well within the normal range, but as you can see, there's been a significant decrease, which we hypothesize probably wouldn't have happened. That's probably more important for people that are borderline subfertile to begin with. So people with lower counts, I can't tell you, but my presumption is that people with subfertility that get started on long-term TRT are more likely to be those people that really struggle with that testicular fibrosis because whatever remaining tissue they had was more affected.
Is there realistically a concern about testicular fibrosis with long-term use? I've seen that talked about a lot, but not a lot of literature in the space.
The only literature, again, same paper, looks to be a little bit less than 2%. So I think it's pretty darn rare. The one thing we don't talk about that we don't have good data on is somebody comes in, let's say their sperm count, their total motile, the amount of moving sperm in their ejaculate is 500 million. So they're well within the normal range. They start testosterone therapy for several years. They come off, they're rebooted, so to speak. Now their total motile count's 150 million. Still well within the normal range, but as you can see, there's been a significant decrease, which we hypothesize probably wouldn't have happened. That's probably more important for people that are borderline subfertile to begin with. So people with lower counts, I can't tell you, but my presumption is that people with subfertility that get started on long-term TRT are more likely to be those people that really struggle with that testicular fibrosis because whatever remaining tissue they had was more affected.
Do you think this could also be an effect in people who took pro-hormones from GNC or a SARM cycle, the research chemicals, or even a steroid cycle for a shorter period of time?
Yeah, again, it's possible. A lot of it we do think, though, is basically shutting off that hypothalamic pituitary gonadal axis. I can't speak to necessarily the paracrine effects or the local effects of these different hormones within the testicle. The most of the data we have just talks about the inability for the sperm to be created due to levels of LH and FSH, those hormones being close to the sperm-producing cells.
Mm-hmm. Earlier, you mentioned intratesticular testosterone and how it's important for fertility. For someone who's interested in fertility and wants to understand that from a layman's perspective, is there a good way to explain that and then explain how SHBG might be related to that?
Sure. So testosterone is produced primarily in the testicles. There are some other androgens that are produced in the adrenal glands, which are the small glands next to the kidney. But the vast majority of our androgenic hormones or testosterone is produced in the testicles. And you can imagine when the body produces these hormones that there are different levels in different parts of the body. You mentioned SHBG, or sex hormone binding globulin, is a hormone that's designed to, or a protein that's designed to bind to testosterone and keep it in certain areas. There's so much of this SHBG in your testicle, in your bloodstream, and in other parts of your body designed to concentrate testosterone. So when your testicle is producing testosterone, naturally, there's so much of it that is sequestered or held within the testicle due to proteins, SHBG, and other proteins that allow it to stay there. So the concentrations, again, depending on the study, range from 50 to 70 times higher than what's in your bloodstream. So theoretical example, you have somebody with a testosterone of 500. That means they have 25,000 testosterone level of 25,000 nanograms per deciliter in their testicle. We put them on intramuscular or sub-Q testosterone. Now their levels are 1,000 in their bloodstream. The problem is that those high levels go back to your brain, shut this axis off, and now their testicles are seeing a testosterone of 1,000, which is 25-fold less than what they were previously seeing. And those concentrations are incredibly important for sperm production. That's how taking exogenous testosterone can shut down sperm production. You know, a question I've gotten that has come out recently is there are examples of people that are bodybuilders or people on a lot of testosterone therapy that have pregnancies. And that's absolutely a phenomenon. You can imagine if somebody was on so much testosterone that they could actually upset that balance and have almost normal intratesticular levels of testosterone because they're taking so much exogenously, or they're doing something, intelligent and taking additional hormones that maintain that testicular production of testosterone while being on testosterone therapy.
Yeah, it's something really interesting to contemplate. If you have a serum testosterone level pull from your arm of 25,000, then presumably have the same level in the testicular tissue, but you're talking about someone with that 500 natural. If you actually sampled it from, something venous near the testes, you would see that much higher concentration. I assume that's how those are done, but I may be mistaken.
So for intratesticular testosterone, I mean, we've talked about other markers like 17-OHP. Really, those markers are actually taken directly from the testicle, which is not something I'd recommend getting your testicle biopsy to get a intratesticular testosterone level. I mean, a lot of times we were doing these for part of cases, again, in subfertile men who get sperm extraction procedures or something along those lines.
Your example that you brought up, a total testosterone of 500, I think mine was 400, maybe 300s when I wasn't on finasteride. But before finasteride, before HCG, et cetera, I've mentioned, including on the podcast and my initial health podcast, that I have varicocele and heat damage. And before I took anything, I had atrophy of both testes. Both were smaller than the normal reference range, just from the heat damage over time. And then I took HCG and rectified that issue. But I did conceive 2 healthy male children before that, and I had very high SHBG. So, I know that varicocele is a very common question, and people have commented many times to talk more about this, less about prostates, more about varicoceles. But what should someone that might have varicocele or other concerns for testicular atrophy, a lost testy, et cetera, is there things that they should strive for, like high SHBG or naturally optimizing testosterone? Because I've always thought that SHBG is bad because it blocks your free T and you can't build muscle and you just want higher free T. But when you're talking about SHBG and fertility, it sounds like more is a good thing.
Yeah, I think that like anything else in the body, homeostasis or this working from some very small equilibrium fixed point is important. So too much of something is probably a bad thing, but not enough of it is probably a bad thing as well. So these are definitely competing interests by keeping the testosterone where you want it, but also wanting enough free or bioavailable testosterone to go into other places, such as, your biceps or your chest. Just a brief aside about varicoceles. If you want those fixed, I can fix those for you. I do get a lot of questions about varicoceles. There was a paper out of Cornell, I want to say it was in 2016 or 2017, showing increases in testosterone by about 100 points.
100. Yep.
Yeah, this is a paper of Dr. Schlegel's group. Knowing the authors, it's ironic that a lot of them do not correct varicoceles in this space for low testosterone, which again, I think that we would need a prospective, a trial that actually was designed to show this difference. People may argue that difference is not very much, 100 points between people that already are grossly in the normal range. I'd given you that example of a sperm count from 500 to 150 million. When we start thinking about these things, we ask the question, something could be statistically significant, but is it clinically significant? These people with the 100-point increase in testosterone, do they feel different? Do they have more libido? Do they have more energy? Is something improved in their life? And if the answer to that's yes, then maybe we really should be considered correcting these varicoceles. But until we have that, until we have some kind of, data showing that there are health benefits beyond this small increase, that again was in a retrospective study, I don't think it's prime time to fix varicoceles. And I think manipulation and other things that are less invasive than a surgery make a lot of sense.
So is there a secret word or a secret question people can ask to get their varicocele fixed if they want to boost their testosterone? Do they need to say, hey, I've got some pain with this doc, for people that don't have the luxury of sitting down and having a nuanced conversation with you?
Yeah, I mean, so my speech is usually, there are 3 reasons I correct varicocele. Men that are under the age of 18, still going through puberty and have size differences, usually more than about 20%. Which is a little bit subjective because this is me literally doing an exam saying this one's a little bit bigger than that one. I would say that's pretty uncommon. Most people see pediatric urologists. I do every once in a while see somebody coming in for that. You mentioned pain. That's an excellent one, but there are some nuances to that. Somebody's telling me they're having pain. I usually ask pretty detailed questions about when the pain comes, how long it lasts, what makes it go away. And if you're not giving me the right answers, I'm probably going to tell you the pain is very unlikely to be due to a varicocele and correction's not indicated.
After I work out, after I take like pump or nitric products, driving home
Yep.
in the car is when it happens, especially when I'm on HCG as well.
Yeah.
There's your answers, folks.
Yeah, the answers are
That's what it is.
it's true though. It's long periods of standing or sitting because it leads to venous pooling, right? These are veins draining the testicle that are dysfunctional, that typically do not allow the blood to return back to the heart. So anything you do that increases pressure, gravity being a big one, vasodilation being another big one, are going to cause the swelling of this, and then that in turn is going to cause that discomfort. So if you're telling me you get out of bed every morning in pain, I'm going to tell you it's probably not the varicocele. If you tell me you lie down, the varicocele, the pain goes away within a few minutes or an hour. That's pretty compelling. The last thing, and probably the most common reason I repair varicoceles, is for fertility abnormalities. Usually if you see me, you'll get a semen analysis. And if there's any abnormality and you want to have future fertility, we would consider correcting the varicocele purely to maintain someone's fertility.
Do you think that the testosterone increase of 100, does that wane over time, or do varicoceles come back more if you ligate them versus embolize them?
Yeah, I don't know. We don't have follow-up data on that study to know whether or not that continues to go down afterwards. We didn't have a second measurement to know if that was even a very valid representation of a testosterone increase. In terms of recurrence rates, that's a great question. This is another area I've published in, looking at the cost efficacy of embolization, or when the radiologist take a small coil and put it through a large vein and block the veins off internally, versus surgery, which is something I do. I do what's called a microsurgical subinguinal varicocele ligation, or varicocelectomy, which is the tying off of destruction of the veins before they even get near the testicle itself. Recurrence rates have historically been higher, somewhere between 2 and 4% with the interventional radiology procedure, and less than 1% with the surgical procedure. It's a little bit difficult to tell that if more contemporary techniques in interventional radiology have changed whether or not that embolization has approached microsurgery. And I will admit I'm a surgeon. I like to operate, but when I talk to patients about this, I say the recurrence rate is probably pretty similar between the two. The big differences I find is the what could go wrong, the major complications. And one is the radiologists are putting a needle into a very large vein in your leg. You could have a major bleeding complication, which I tell people is incredibly rare. They do this every day. And then for my procedure, there's a small chance of injuring the testicle. Again, that's less than a fraction of a percent, but it's a real risk. And the other thing is recovery. The interventional radiology procedure, most people are back to activity by a week afterwards. Most of the time, mine is 10 to 14 days. But again, if that 4 days is the difference between you going back to work and making money and not, I totally understand that. But these are important conversations to have with your physician before pursuing some kind of correction.